Welcome back to another great episode of Inside Medical Malpractice, and thank you so much for joining us again. I took a little break over the last 3 months to travel through Southeast Asia with my husband Rick, escaping the cold Canadian winter and exploring a new corner of the world, but I am so happy to be back here with you today. We're going to discuss the fourth in a 5-part series on some of the most problematic issues in healthcare that result in medical malpractice cases. As a reminder, those issues are inadequate patient assessment, intervention, or care, medication errors, failure to communicate adequate information, unsafe or improper use of equipment, and infection control. These 5 issues aren't new. They were identified and studied and reported nearly 50 years ago. But from my experience, at least one of these issues, and sometimes several of them altogether, still today play a significant role in malpractice cases. I started a series on this topic because I wondered and I hoped that if we all knew more about the issues and their outcomes and really understood not just how badly they affected the lives of patients and their families, but how they can devastate the lives of doctors and nurses who care for them, that we could all do better. And I hope that with more understanding of the issues, we could all make a difference to the most important bottom line, which is patient safety. So let's learn some more today. My guest is Nova Scotia lawyer Ray Wagner, and the topic today is unsafe and improper use of equipment. I've known Ray for several years and had the great privilege of working with him as an expert on both malpractice cases and class actions, and he has a wealth of knowledge on the area of equipment problems. So welcome, Ray.
Nice to see you again, Chris, after your holidays, and see that you're back safely in Alberta.
Thank you. It is nice to be back. Ray and I have had kind of the fun time of meeting in strange places at different times. We've met in Halifax. We've had dinner in Toronto. We met last year just by fluke in Miami and had a really lovely dinner out. And we were going to meet again in Florida this year, but he was in Florida and I was in Asia. But we do get together once in a while. So it is great to see you again, all the way from the East Coast.
Well, the pleasure's all mine.
He just explained that he has a seagull raising some babies and hatching eggs just outside his window. So if you hear it, it's going to give us a little bit of confirmation of where he is in the world and a little bit of East Coast flavor. So let's talk just for a second about this amazing guy, Ray Wagner. Ray is the founder and principal of Wagner's, a law firm in Halifax, Nova Scotia. He has dedicated most of his 42 years of legal practice to representing injured plaintiffs, with a focus on class action, medical negligence, and a special focus on birth trauma and personal injury. He is well known for being a compassionate advocate, for his candor, his civility, and his good practical advice. Ray places high value on timely and equitable resolutions and has achieved significant settlements for many of his clients. He's an experienced trial lawyer, repeatedly recognized by Lexpert and Best Lawyers. He's a recipient of the H. Bruce T. Hillier Award and the Lauren Clark QC Access to Justice Award. He's appeared before all levels of courts in Atlantic Canada, as well as courts in Ontario, Quebec, Saskatchewan, and the federal and Supreme Courts of Canada. He routinely presents to members of the Canadian Bar Association in Nova Scotia and Ontario, and trial lawyers associations across Canada, the American Association for Justice, La Barreau de Quebec, Osgood Class Action Symposium, and many others. In 2015, Ray was one of the 5 finalists for the Public Justice Trial Lawyer of the Year Award across North America for his amazing representation of clients in the multi-million-dollar settlement L1V Nova Scotia Home for Colored Children. This was a class action regarding historic institutional abuse. In 2021, he was recognized internationally for his work as a passionate advocate and trial lawyer when he was inducted as a fellow of the American College of Trial Lawyers. Many of his cases he's worked on have also improved the quality and safety of all individuals for the future well-being of society. Nice job, you.
Well, thank you for that. Even you practiced for 43 years, there should be something on the resume, hopefully.
Yeah. Well, you've got some amazing stuff, so thank you. And thank you again so much for being here. Before we dive into talking to Ray, I'd like to start with a discussion on equipment errors. The first lawsuit I ever reviewed as a nurse expert involving the improper use of medical equipment was something that was so seemingly simple, but had such a difficult outcome. The story goes like this. A 4-month-old baby was brought into the emergency room with lethargy and vomiting, ultimately diagnosed with a bladder infection. The ER physician ordered a dose of IV antibiotics to be followed by 10 days of oral antibiotics. The ER nurse tried but failed several times to start an IV in the back of the baby's hand. After the 4th attempt, she decided to go to the NICU to borrow a piece of equipment called a vein illuminator, which lights up the skin and the underlying tissues and makes the veins more obvious to see, and to assist her in the IV start. On her way out of the ER to the NICU, she bumped into a paramedic that she knew quite well. She told him what she was up to, and he offered to lend her, kindly, his high-powered flashlight to illuminate the vein. She took the flashlight, placed it in the palm of the baby's hand, got the IV in, but the flashlight result caused third-degree burns to the baby's palm. And you know how babies keep their little hands in fists all the time. There was so much pain and scarring and infection and bleeding, multiple surgeries to release the adhesions and the scarring as the baby grew. Just terrible stuff, which could have been so easily prevented with the use of proper equipment. As a general statement, I think as a nurse and a consumer of healthcare, that it's fair to say that it just isn't too much to ask that we should all be able to rest in the knowledge that doctors, nurses, and other hospital personnel use equipment that is, first of all, safely made, working properly, is regularly inspected, and up to date. It's also fair to assume that the people using that equipment have been properly trained, know how to troubleshoot for problems, and can interpret the information gained from the equipment. Patients in hospitals are exposed to so many medical devices. Just think about it. IVs, IV pumps, blood pressure machines, heart monitors, blood sugar monitors, defibrillators, anesthetic machines, and implanted devices like knees and hips. There are surgical saws and so many medical instruments, just to name a few. Specialized equipment is all along the spectrum of healthcare delivery. It's used to make the original diagnosis, to decide on and provide correct treatment, to monitor and assist in a successful recovery, and in many cases, to sustain life. If there's a problem anywhere along this continuum, whether it's a product defect, a maintenance or repair problem, operator error, or interpretation of the information, it can lead to injury and even death. Injuries can happen when the equipment is faulty, as in hip replacements that loosen or misalign, when it's not used properly, such as when an IV pump is programmed to deliver too much or too little fluid or medication, when the information is not interpreted properly, like the information from a cardiac monitor is misread, a fetal monitor is misread, or even the temperature gauge in a bathtub is ignored. Care providers, manufacturers, distributors, and the institutions that provide healthcare have a significant role to play in the safe use of equipment. In our developed world, hospitals are required to report medical device errors and incidents, but because the reporting itself isn't always monitored, the exact stats and toll on patients is relatively unknown. One 10-year retrospective study from 2018 backwards revealed that 1,400 Canadian patients died and 14,000 were injured in incidents involving devices that were designed or intended to help. When many patients are all injured or suffer complications by the same device, a class action lawsuit is often follows, which is something we're going to talk a little bit about today. In August of 2020, for the first time, the Canadian Institute for Health Information, often known as CIHI, released an analysis focused on the most commonly implanted medical devices, some of which have resulted in a significant volume of patient injuries. In order of frequency in which those devices are implanted, they are cataract lens, knee replacements, hip replacements, coronary stents, ear tubes, pacemakers, IUDs, spinal fusion and fixation hardware, transvaginal mesh implant and TVT or tension-free vaginal tape procedures, breast prostheses, shoulder replacements, and defibrillators. Odds are that anyone listening into this podcast today knows someone, or maybe several people, who've had one or more of these devices implanted in their body. And you may know someone who has suffered complications from them. In my own immediate family, I took stock of this last night. There are cataract lens insertions, 3 knee replacements, hip replacements, 2 breast prostheses patients, a coronary stent in my dad, IUDs, and a pacemaker. In my own immediate family, I've got that. So today we're going to talk about errors with equipment, and we're going to talk about the legal actions involving some of the most commonly used equipment. And let's take it away to Ray. I'm going to turn the conversation over to him, first of all, to start to share the details of some malpractice cases involving medical equipment. These are real cases from his law practice. And listen in as he talks to see if you think there was a moment or an action or a person, a time that the errors could have been prevented, because I always find that a fascinating part of all these cases. So take it away, Ray. Let's hear what you have to say.
Yeah, so I'm going to talk about a few in general terms, and you've covered, Chris, a fair bit of territory there, and I'm going to overlap in a couple different spots where we've seen cases. And we've been involved, some successful, some not. One thing that, of course, is there's 2 different types of categories, I would say, at the outset. One relates to operational error, and that is equipment that is used, and the operator, unsophisticated, maybe uncaring, or maybe sloppy, or maybe too busy, that causes the interface between the individual provider of healthcare and those the equipment itself, and the other is just malfunctioning equipment. Usually, I could say, in overall, where we have malfunctioning equipment from either of those 2 cases, often the case is driven mostly by the medical malpractice aspect of the case, and often the manufacturer of the equipment is not included. And there's some very good reasons for that. Before we talk about individual cases here. And the reason is that when you start meshing a product's case with a medical malpractice case, you're channeling in 2 different directions. And one is the medical malpractice. We're all familiar with that area and how we manage those cases. And we're also, for those that do product cases, also understand that it's a different channel of information that you're looking at. And often, one can stumble the other. And that's without talking about class actions, and we'll talk about that later. But so when we're looking at those, the questions, often if it's a clear malfunction and there's no medical error, then it's clear the channel that you're going to have to take. If it's an operational and it's really just trying to shift blame, then probably your medical malpractice is your best case to go. When it's completely unclear and you're in that zone, you do have to go on both channels in the same proceeding and to proceed. So, some of the examples, and I'll talk about them. Oximeters are a good one to start out with. We had a case, a very, very tragic case, where an infant went into respiratory arrest, cardiac arrest. It was asystolic for 15 minutes. You can imagine what the recovery was like. It was very poor. But it was a failed oximeter. Now, it was hard to tell in that particular case whether it was the oximeter that had failed. Because remember, the oximeter often, after you have this failure, by the time the client gets you, that oximeter is gone, could be gone anywheres in multiple usage of it afterwards. Or was it the the nurse in that particular case, where the mother was sleeping in the same room as the infant because she had been up with a respiratory issue that led her to admission, to not disturb her in her sleep because it kept going off. Now that was, so that was a case there where it was an equipment failure because it didn't go off when the child stopped breathing. But it was very clear that we had a very strong case in terms of the medical care provided by the hospital and the nurse. And so we didn't pursue the oximeter. It would have been too difficult. And often we're looking at the channel in terms of litigation because of the significant timelines, the path of least resistance.
So just to be clear for the non-medical audiences listening in, because I'm always in awe of how much medical knowledge you malpractice lawyers have, is an oximeter is it's a little monitor that on an infant often goes on a finger or toe or sometimes tied around the wrist, and it measures the blood oxygen level. So it would be picking up in this particular case if the infant stopped breathing or the breathing became slow or inadequate and the oxygen level in the blood dropped, it should alarm. But, I'm kind of cluing in on what you say too about over alarming, because babies are often wiggly and they move and they suck and they pull things off and, all those things happen. So it can become problematic to know when to listen to that alarm. But I also want to just clarify too, like something you said, you just taught me something, that if the equipment itself fails, that's then you're going to pursue action against the manufacturer. But if it's the operator error, then you look at it from the lens of a malpractice case. And if those two things overlap, then you might have to go down both roads. Did I hear you right on that?
Yeah, for sure. And, the problem is the information that you're required to be successful. And we'll talk about this more in the class action scenario. But if you're going to get information on the product manufacturer and the particular product device where it was made, often made outside our country and in other jurisdictions, and then you got to get into the document dump that you're going to inevitably deal with. Excuse me. And that could be thousands and tens of thousands of documents. And it can be extremely costly. Medical malpractice is not cheap, as you know, and it is getting more expensive all the time, unfortunately. But that is a channel that you may not want to go. And, and the other problem that you have is that by the time the client gets to you, that equipment may be gone. It could be in the dump, for instance. It could be serviced. It could be, or it may not have. It may have been idiosyncratic in terms of its function. That something glitched in some software that was providing directing the equipment.
Or it could still be circulating in use, and nobody's, it just hasn't resulted in any particularly bad outcome.
Right, and until you get repetitive outcomes of the same equipment, as, say, at different hospitals, maybe in the same hospital, then we're talking about individual equipment that malfunctions versus a stream of equipment that malfunctions. So that's a different story altogether too. Also, working for you against you is the fact that if it's properly serviced and they're keeping up with their warranty requirements on the equipment, and there's been multiple people using it afterwards with no complaint of malfunction, then that drives your intuition towards the operator error component. But again, it's difficult, but there are certainly cases for that. So oximeter is a good one. There's a whole host of other ones, but failure of equipment, unsanitized colposcopy equipment. Now, that led to a class action, but can be an individual case where there is an infection and it's dragged back by, forensic evidence with respect to the type of infection it is, and it can be tied back to the machine. That could be, a particular case, but again, we've done that in a class sideways situation. In another malfunction area, and I'm going to go skip over a bunch of them. This is really a lot of these all seem to come back to some involvement of operator error, except in certain cases. Failure to transmit information with respect to newborn screening. That is kind of, again, a systems error, which involves systems and equipment. And if you have a glitch in your software in terms of communicating from one testing hospital back to another birthing hospital, and we have had that in a particular case where it was tested at our main hospital, our tertiary hospital here, and that's the central repository for that information, transmitted to the patient's parents, and so hypothyroidism was not diagnosed until 14 months post birth, and of course led to a significant brain injury.
No, was it a communication error, or was it like it was faxed and not received, or some crazy thing like that? What was the equipment error in that?
Yeah, it fell to two hospitals, and so we never really found out exactly where the breakdown was, but the servicing hospital, the testing hospital, communicated the information to the birthing hospital, and in that case to the neonatologist who was involved in it, but nobody communicated it with the patient, so they didn't know about it, and so that's led to a lot of litigation on that particular case. Through all the we've been litigating that now, and it's gone up and down a couple times in the Court of Appeal, and it's a crazy case because nobody, certain individuals accepted responsibility and others did not. So but again, it's a communication error, a systems error, that if you could say is equipment. Another one that's interesting is the elevator was stuck between the pre-birthing unit and to the operative room. We had to go to an operative birth and with a C-section, transporting the patient between one floor to the next. The elevator failed, so critical time was lost. And minutes matter, as you know, in terms of resuscitating or having a birth and resuscitating the fetus, the infant. So that's a particular one. Another one that we've seen is, and this is kind of peculiar when you look at equipment and hospital equipment, is side rails on beds that are not properly engaged or malfunction, and the person rolls out and falls and can cause quite devastating injury. We've had an ablation where during the ablation surgery an explosion happened. We don't know yet what the cause of that was, operational error or malfunction, but that's something that is kind of ongoing. The interface with EHS, Emergency Health Services, ambulance operators, the interface of critical information in a particular case that we have, where the critical information of the EHS went to and attended, wrote up detailed notes because it was just after a birth. The mother wanted to nurse her son before she went to the hospital, and then she got herself to the hospital several hours later, about 4 or 5 hours later, and the critical information that was there that the EHS people had determined was not communicated to the physician and then the person was discharged in a very, very tragic outcome.
Was it critical information about the mother or the baby? What was missed there?
The baby was fine. Yeah, this led to a multiple amputation as a result of infection that went untreated. It was, yeah. She had a perineal tear, 3B tear, so it was quite significant and led to that. So these things are all equipment. I mean, I just bring these, we can talk a little bit more about, and we will later, about hips and knees and stuff like that, the implants that are actually coming. But when you start looking at, and I started thinking about this, I thinking all the equipment failures, for instance, in terms of the COVID, the failures to use proper equipment to prevent the spread of illness in the disease within the hospital setting. It was done well, generally. It was done poorly in long-term care, very poorly. And that's another setting that involves healthcare individuals. And there were tragic outcomes for a lot of people, elderly people, some not so elderly, who passed as a result of contracting COVID through the failure of providing appropriate prevention.
Yeah, it's going to be interesting to see how that plays out. And we've had a guest on the show, Gary Well from Will Davidson in Toronto, and he did a conversation about some class action cases in long-term care in Ontario. But it is going to be fascinating to watch that. Can I go back and ask you just some snoopy questions about some of the things that you just said? So I'm kind of fascinated by the elevator breakdown. And I knew about that somehow. I knew a little bit about that case. How do you even, as a lawyer, approach that? And I mean, who's the defense in that case? What is your angle and approach? And for lack of a better word, who's to blame at the end of the day? And how did that case turn out?
Yeah, so there's a lot of potential in terms of who you're going to sue. Typically, you would start with the hospital and you say that it was poorly maintained, antiquated equipment, or whatever it may be, and see how that plays out. You got to worry about limitation periods too, but they also have discoverability. And if they have some information to suggest that somehow it's the actual equipment and the equipment design, then you would explore and move on to the next topic of whether including the manufacturer or not. But I would say it's a hospital failure to maintain the proper operation, and that's the first line of attack. To go to the other, you may be going off into there were other issues that caused delay, but that was one at a critical time when they were transferring to the operative unit. So that case is still ongoing, and we'll see where that goes.
I can just feel the panic in my heart just rising thinking about that case because, as a labor and delivery nurse, I've been in situations where there's been a delay that you have no control over, whether it's a doctor who can't get to the hospital or an anesthetist that's stuck in another OR or a piece of equipment that isn't out of the sterilizing room or you have to order it from another unit. And even like 2, 3, 4 minutes feels like a lifetime. I can't even imagine being stuck in an elevator with an urgent C-section patient on the way to the OR. I mean, from the healthcare perspective, and for the patient, I mean, I can't even, it's just almost too much. I just want to ask you too about the other case that kind of caught my ear was the ablation case. And again, are we talking about uterine ablation here?
Yeah.
Yeah. So just again, for the non-medical audience listening, and a uterine ablation is when a woman has problems with excess bleeding or issues with the uterus is filled with a balloon and then very hot liquid that basically burns the inside of the uterine lining and scars it so the bleeding, hopefully the excessive bleeding stops. It's a way to deal with heavy uterine bleeding. But like, what exploded? Like, what happened?
Well, we don't know if we're yet to what exploded because the case is just recently filed, so we have to disclose risks. Stuff like that. But I just raise it to say that these are, when you ask me to do this, I mean, I've gone through a lot of product cases over the years. I do kind of dump every time we do a case. I dump the information. So this gave me a good opportunity to look back at some of the stuff. But most of the products cases, when we get deep into them, is either the failure of the hospital, and that's where you got an individual case, or in the class setting, and we'll talk about that. These cases are often more suitable for a class setting. If it's just a one-off and you had multiple use before and multiple use after the same piece of equipment, it's very difficult to show that it's malfunctioning, and you just generally wouldn't go down that channel unless, but it is sometimes a combination, again, of operator error and maybe naivety or indifference or whatever. It does happen those ways, unfortunately.
Well, I will tell you, I practice in labor and delivery units off and on for 30 plus years. And, there's lots of new equipment coming in, whether it's fetal monitors or IV pumps or, anesthetic pain machines, all sorts of blood pressure, everything, temperature, like electronic thermometers. And the reality is that, you attend a 15, maybe 30-minute in-service, and they have to get all the staff through before they bring this new equipment on. So you attend a 15 or 30-minute in-service on how to use your equipment properly. And maybe like 6, 8, 12 weeks later, the machine is then all the old equipment's gone and the new equipment's there. And your recall and memory and or practice of that new piece of equipment is so limited. You've done a million things and worked 15 tough shifts between then and now. So it's, I understand the challenges of trying to get lots of staff oriented to new equipment, but also the reality of being the staff that showed up one day and here's your new IV pump. And it's like, well, you know,
Yeah, the another issue I think related to that, and I think retraining and recertification on the equipment and critical areas is very important. But you don't have to train everybody on the best practices because you may be in situations that you find that the person that's key is off sick, or maybe the other person is on holiday, and you're left with somebody who has very little experience. And so sometimes in urgent or emergent situations, you have to go with what you got, and those are unfortunate circumstances. So some training is better than no training, unless some training leads to undue confidence with respect to operating equipment. And I've seen that happen, and especially in the residents, when we're dealing with residents in malpractice, the things that they may do that they're trying to show their junior resident how well they could do something. And we had an awful case when we were doing a central line placement, and they hit the vertebral artery, and as opposed to a venous that they were looking for, and caused a stroke, and a devastating locked-in syndrome was caused by that. So you can. So it is a tough balance. The balance is to make sure that you have at least sufficient backup for when those, when people are sick or off on holidays or whatever it may be, to be able to fill in the best you can, but at the same time not get overconfident and then say I can do it instead of getting the proper professionally trained individual to come in and do the procedure.
because sometimes in the hierarchy of healthcare, it can be difficult to ask for help because you want to seem or appear as if you're competent, the smartest person in the room. This is just a little question off the top of my head, because when you're talking about, we often refer that in the hospitals as the super user, the one or two people that know how to really truly operate the equipment. And what do you have thoughts about the electronic healthcare record or the electronic medical record as a piece of equipment that's been related to malpractice outcomes? And would you consider that equipment error if there's misuse or misreading or miscuing from the electronic medical record?
Well, the electronic medical records, especially when it was interfacing with the written records, and we still get written records, of course, but I would say that's medical equipment. I would describe it as such. Where the problems often arise is that you have different systems that are interfacing with each other, and these are highly technical, programmed systems, often programmed maybe in Texas or somewhere like that. And a number of the major systems are manufactured or produced, formulated in other jurisdictions. And then you got one that comes from X-ray, another one does the general management stuff, and another one comes from another service, pathology, for instance, and they're interfacing it. And then when you try to go and try to understand the medical records, what was readily available and what was not, what had drop-down menus and what wasn't observed, what was the tracking in terms of looking back who was there and at what time. Your problem often comes is that you can't find somebody that can really tell you all that stuff, because there's different individuals that come in, and the head technician or whatever And I found this in a particular hospital when we were dealing with forensically looking at the electronic records. And you couldn't find anybody in the hospital because all the people that were there with the integration of the software systems had all left for other jobs. And so you really, and then you were talking to the manufacturer, the producer, who wrote the data for these systems, and it became, when we were doing it in a very tragic case, it became so massive, and we spent hundreds of thousands of dollars. I think it was about $150,000 we spent trying to just look back in the medical records and track everything. But it is a system, and there are different systems that are used, and they're trying to make them publicly available to physicians where they can access them, and all this integration and interfacing is great, but it's hard to dig into, and of course it makes it more prone to potentially to people that want to steal data. That creates another data protection issue and another potential class action.
Right. That's a whole another up and coming profession, I think, hey, forensics and the data protection, the information protection. Are you able to share with us the outcomes of any of those cases that you mentioned a few minutes ago, like how they turned out? And I'm also be interested to say, if you got experts involved with them, what did the experts who reviewed the case or cases have to say about both the standard of care and causation in those equipment error cases?
Yeah, so in the equipment care cases, they're mostly in the class action setting, and I can talk about that and more in that setting. We do usually when you dig down in terms of the equipment, if it's not repetitive, then it's usually operator error. So that's where you usually stick and stay for the reasons I already expressed. But for instance, let's talk about in terms of the unsanitized equipment, and it was, I shouldn't say unsanitized. It wasn't up to the standard of care with respect to the proper sterilization. There was sterilization done, but it wasn't to the standard of care. So in that particular case, we had an expert from the United States that is an expert and has commented in other cases about what that standard is. And then, of course, from the medical records, we know that what they were using to sterilize the colposcopy equipment. And so so that was really, and so when you talk about that in the broader context, you see, because I know you got a varied audience, we talk about a breach of the standard of care, and that often most people probably hear and understand that. It's the causation piece that often is confusing to people that are not familiar with it. And causation, of course, is did the breach of the standard of care materially cause the outcome, the negative outcome, and that's often where medical malpractice is fought for those that are maybe unfamiliar with it. But in class actions where we're dealing with colposcopy things, is the question of standard of care in terms of general causation and specific causation. Now, if you don't sterilize the equipment, we had nobody in that class developed an illness that we could track back to the colposcopy, even though the settlement allowed for that to happen. But everybody got paid who used the equipment for the concern and the anguish and the stress caused by not knowing whether there was an illness or an infection that can be rooted back to the colposcopy equipment. So that's kind of something like that. That's one particular case. We can talk a little bit when you're ready, talk a little bit about implants and stuff like that.
Yeah, well, I think we'll do that in just a sec. I just want to clarify again for the audience, a colposcopy is a sampling of the cervix when there's been any question after pap smear that there's any unusual or worrisome cells there and any indication at all of inflammation or cancer of the cervix. So colposcopy takes a little sampling or piece of the cervix. So, like, what were they So who was the defendant in this case? Because the nurses and doctors, I'm presuming, wouldn't know or be involved in the decision about how the colposcopy equipment was sterilized. Was it the hospital or the clinic that was on the hook for this?
It was entirely the hospital. We never brought an action against any physician in that. And, I can say that in terms of medical malpractice, our practice is that we don't try to bring anybody in that we don't have to. And that's not, we're not here to cause grief. Really, we're here from our perspective is to get to the answers, to provide, the best result we can for our clients, but not to cause harm, because we know that, almost all, there are a few, very few medical practitioners that really are doing their best. But I say what I would say to them and to everybody is that when I get up out of bed every morning, I say, I'm going to make some errors today. And I just hope that I don't, I do. I know I'm going to make mistakes. I am. And I just hope I don't cause anybody harm. And that's the way I look at it. And if I do, well, I have to deal with that. So everybody makes mistakes every day. And sometimes even the most proficient and specialist expert in a very esoteric field will still make a mistake every now and then. And most of the time it doesn't cause harm, but sometimes it does.
Well, first of all, I just want to say that I appreciate what you've just said and the compassion and kindness with which you said it. And as someone who knows you and knows about you and knows other people who know you, you are well known as someone who has a kind of compassion and understanding and not out to, get anybody, but to seek compensation in the fairest way possible. So I appreciate about you personally, that's true about you. And the other thing is, I think as healthcare providers, I've made mistakes too. And luckily, I don't think by the grace of God have caused serious harm. But it is like a load that you have to learn to carry your entire career, that the potential is there every single day, not just to mess up, but to mess up and really cause serious harm or injury to someone. And I was talking about that with Steve, the producer, just the other day, because he's got a very compassionate view on trauma and difficulties in people's lives. And we were talking about the skill it takes to learn. And I think that often about you malpractice lawyers too. I mean, you hear and see so much unhappy parts of life. So the skill to carry that without letting it weigh you down is, I think, offset by what you just said, by the desire to do good, to do good and do right by people. So thanks for that. That was a nice thing you just said. So I want to ask you a question. If in any of these cases, it turns out that the doctors and or nurses are partially responsible operator error of the equipment that's led to harm and resulted in a malpractice lawsuit, how do you question them when they defend their actions with, I didn't know, or I haven't used that equipment before, or I was pushed to another unit where I hadn't worked and I wasn't very experienced, I hadn't read the instructions? How do you question those people?
Well, I certainly question where I would go with that. I would go back in terms of trying to address whose fault that is. And generally, it's the lack of training and lack of administrative responsibility in the institution that provides the service. Personally, I'd love to get away from personal and having to address these issues with a particular nurse or a particular doctor. I'd much rather, if possible, to deal with the institution at an institutional level. Yeah, for me, it's much easier, especially in the context of jury trials and that we do. And if you're dealing with an institution, a cold factory or something like that, that's much different than dealing with Mother Teresa, a nurse, or a doctor who is God.
Yeah, I'm sure it is. I'm sure. But that's kind of interesting because when I read through examinations of discovery, it's not uncommon that that's a response. I didn't know, or I hadn't been trained, or I hadn't been shown, or I'd forgotten, or hadn't read the book, or whatever it is. And I often wonder how that scenario is going to play out. And I talk to nurses a lot about, malpractice and negligence. And I always like to kind of approach them with, you need to know, you got to know if you're going to use that equipment, you're on the line here. You're the one that's responsible. Take the time to learn that. So I find, and I think just already from talking to you about the case that you've mentioned, there's this just so often multiple overlapping issues of these 5 issues that I kind of introduced in the beginning. And those are communication, assessment, med errors, equipment errors, and infection control. Do you find that in these equipment error cases too, that I know you mentioned one involving communication when the tertiary hospital didn't communicate the thyroid test results, and you also mentioned infection control with a colposcopy case. Is that a common finding for you, that it's not just one issue, it's 10?
Yeah, that's as we move along and become more specialized, it becomes more terrifying for us to deal with, because you like to deal with everything in one. It's not like, a family physician in their own office made an error. That's much easier because you can deal with that. But when you're dealing with an institutional situation where people become more and more specialized, especially in tertiary hospitals, they're often, then you're dealing with a number of individuals. And in the ER, if somebody's there for a long period of time in the ER, sometimes they're stuck there. Then you're dealing with a lot of ER physicians. Yeah. And, and that's, so where do you get the, how do you deal with that? And that's very difficult. I had another situation where we had somebody who she fractured her spine, and she was a little older, and was in a regional hospital, and they called to the tertiary hospital, and they had a caucus of 5 neurosurgeons. Well, that's a terrific. You sue 5 neurosurgeons with the treatment plan was not. They didn't. What the problem was, they didn't stabilize her, and then she became quadriplegic. That's because they're moving her around, which they should not have done, because she had ankylosing spondylitis, and so she had a very brittle spine at the time too. I mean, she was not in good condition, but nevertheless, we never did pursue that case. Unfortunately, she has passed away. But that was a case there that, are you going to sue all the neurosurgeons at a tertiary hospital because of some collective advice that was given? That may have been, who knows whether it was properly communicated in the first place, et cetera. It's a terrible thing. And then if you start drilling down away from ER and into the subspecialties, and you got a cardiologist comes by and they deal with the heart, and you got somebody else, a rheumatologist dealing with other kind of systemic issues. You got an internist, and and when they park themselves only in their specialty, and this is what I find where it's problematic, is that they even though they're getting other information, they may have other thoughts about it. They don't really share it with another subspecialty, and so you get everything starts to get compartmentalized, and then when it gets compartmentalized, is who's to blame for the unfortunate outcome. And so there often is a collaboration issue that sometimes we see in these medical malpractice cases.
Yeah, it's so much more complicated and difficult to unravel than you can even imagine. Hey, I want to move on to talking about class action with you, because I know that's something that you're currently involved in and is a big, big part of equipment errors. But before we just move off of this topic, I just want to just mention to the audience that for another case study on equipment errors, there's a podcast on Inside Medical Malpractice by Leilani Schweitzer, and it's titled Transparency, Compassion, and Truth in Medical Error. Leilani's young son died when the nurse turned off the alarms on a machine that was monitoring his heart. And she did it for the best of reasons, because the machine kept false alarming and nobody was getting any sleep. And the nurse turned the alarms off and unwittingly turned it off on every single possible level she could have. It was an operator error and an equipment error in 1,000 ways. But it's also one of the top 5 downloaded episodes of all time on the podcast. And it addresses this issue of equipment error in a much more personal level than I think Ray or I ever could by seeing it from the outside. So So if you've got the time, have a listen. It's Leilani Schweitzer, Transparency, Compassion, and Truth in Medical Error. So let's move on to talking about some class action. Can you first of all, I sort of did a very layman's version of describing how and when equipment error results in class action, but can you first of all, just for the audience that might not know, describe a little bit about what a class action is and how and why equipment error might end up as a class action versus an individual malpractice lawsuit?
So class actions are a very peculiar beast. Even more, I know that civil litigation is complex and foreign to a lot of people that are not participating in it, and hopefully you don't. Is a class action as a species unto itself, and so it comes in three phases. And the first phase is what we call the certification stage. And the second stage is the common issue stage. And the third stage is individual assessment. So there's three critical stages, as opposed to when you start an action, a civil action, you start the action and you go to trial. You have intervening steps, of course, as you do in class actions, but we have three major steps. And so the first major step is whether the case should be properly certified. And that typically comes in 5 criteria, and I'm just going to tell you what they are. I'm not going to describe them much because it is complicated. But whether there is a cause of action, in other words, is there a breach of the standard of care, mismarketing, production errors, or whatever it may be. Then the second thing, are there 2 or more people who are impacted in a similar way? Now, I've not seen a 2-person class action certified ever.
That's not many people, is it? 2.
But it says 2 or more. That's what it says, right? Yeah. And then are there common issues? In other words, because there's so much individuality, of course, in all of us, but is there something common about that particular product as it relates to a class of individuals? In other words, it repeats itself across a spectrum of individuals. Then is it the preferable procedure? In other words, should everybody go off, and if there are 1,000 people that are impacted, should there be 1,000 civil cases or one case that'll deal with 1,000 people? And the fine is you got a representative plaintiff. In other words, somebody that has been impacted similarly to the class. So you have to determine that, and that's an upfront thing. And then when we're dealing with this, when we're doing a cause of action, we're dealing with a couple different things, and this relates to the common issues. The common issues are the common issues determined by the class certification process. And so what those issues are, and they could be, was the product improperly manufactured? Was there, a mismarketing of it or something like that, or whatever it may be? And those are common issues, and they're usually not very many. And so that's what we focus on in terms of the common issues part. But when we're looking at it from certification, is there a cause of action? We look at it from a different perspective than what you might think on an individualized basis. And what we look at it is there a breach of the standard of care or another negligence allegation? And once you get past that, you go to causation. And the causation, though, gets split. It gets split between general causation and specific causation. And when you are generally in a medical malpractice case, you're only dealing really with specific causation. Did this breach of the standard of care or error or product defect materially cause this individual's problem? And so in class actions, you look at it, is there general causation? In other words, can this product cause this harm across a spectrum of people? It's a different causation question. And that's the causation question you're dealing with in the first 2 stages, certification and the common issues trial, which only relates to the conduct of the defendants. So that's what makes it all this very peculiar. And then when you get to the third stage, is this particular product in this particular individual cause their particular problem? Back to the kind of stuff that we usually deal with in medical malpractice. So it's a technical area, but sometimes class actions are faster, and sometimes just a medical malpractice case is the better route on a group of individuals. And the reason that class actions can be faster, despite the complexity and the enormity of it all, is that you get case management right from the start. So you get right into it. You get a certification schedule. You have a judge dedicated to it, and you get to the to do the certification hearing. Often you have to deal with appeals and these things. Almost every certification is appealed. Sometimes the Supreme Court of Canada or attempts are made. We'll talk about a particular one as an example shortly. And so you can, but nevertheless, you can get through that process relatively quickly, and then you can get your experts and go to trial. It'll be organized by that particular judge dedicated to your particular case. So you can deal with things maybe in 3, 4, or 5 years. If a standard medical malpractice case, we're booking now. If we saw a judge and booked a case right now, we're booking in 2026 and 2027. That's not considering everything that we are doing beforehand, like starting the claim, expert opinions, document disclosure, discovery examinations. So there are cases that is better. Now, what is better with the individual case is that generally individual cases are worth more on a case-by-case basis. So you take the class, it's rough justice, individual case, a case that you may get $100,000, $150,000 in a class proceeding, you may be able to get $500,000 or more because in an individual case because they're assessing more things. And so it's the determination of whether rough justice is the right way to go, or is it an individual assessment? I would say that if there's a large group of people, are you going to manage and do 50 cases? Say if you had 50 cases and you did them individually, every time when you did the first case, you go to the second case, they're going to argue the same thing they argued in the first case. Go to the third case, they're going to argue the same thing they argued in the first and second case. This is how the defendants work in class proceedings, the corporate culture in terms of obstruction and make it complicated and not to let you get ahead of the game where you satisfied causation and you can move from and reach the standard of care and just move to an assessment of damages. It doesn't happen that way. In class actions, yes, it does. And then it's resolved for everybody except for the specific causation because somebody may have had the wrong device or may have done something stupid like jump off a bridge or something like that to cause a fracture of their product.
I'm just thinking too, like if you had to try 50 or 500 or 1,000 or 10,000 cases, what further backlog that would cause in the court system. Because I'm also just thinking, your perception that class actions move quickly, and quickly is 3 to 5 years. Like, it doesn't sound that quick, but I mean, I know in the legal world, that's about as quick as it gets. But I've also been involved in some class actions where they just went on forever, for way, way, way longer than that, like dating back to 2008, 2009, and it was still going through the medical records and all sorts of issues there. It seems to me like a real David and Goliath situation when it's you suing, let's say, someone like Johnson & Johnson or a large corporation like that. What is the typical response you get when I imagine you don't call them or email them, but you send them an official letter? And what's the typical defense of the defendant in that situation?
Well, there's a number of different defenses that they use. One of course, is delay, and the delay is is the defendant's benefit because it stretches it out, makes it more costly. But if you start it, you got to finish it. And talk about class actions that can take a long time. I did a class action that took 16 years. Now, at my age, 16 more years is I'm not going to see the end of that case. I can start it, but I'm not going to see the end of it. I'm sorry, your question, and I just missed it. Just my mind was.
Well, it's just, what is the typical defense? You send Johnson & Johnson a letter, and they say.
Yeah, I never sent a letter to them. First off, I would just start an action. I would sue. I would have done the background stuff, and I would know what's going on. and had a sense for the case, start the action, and then you get appointed some very big law firms with tons of lawyers and and budgets that are not capped. So you get a lot of pushback, and it is a David and Goliath. But the judicial system is a wonderful way to get some equality, and you can do these cases. You have to expect a rough ride, but some of the back to your question is some of the issues are, well, for instance, in our failure rates are only like less than 1%. Well, that's fine. So, I wrote down some of the ones that I had heard, and I just see if I can find them here.
Like, you mean that's what the corporation or the manufacturer be saying? Our failure rates, that's their response. Our failure rates are less than 1%.
I'm just saying some. I had quoted them here. Here's some of the quotes. And this is tobacco is the benchmark for corporate obstruction, because you know what tobacco did. These reframes you'll hear, and this is in the particular case that I'll talk about, which is the right pro femur hip implant specifically. When we get to that, insufficient evidence. Contribution remains inconclusive. Identifiable excessive weight in the patient. That's victim blaming. Highly active patient, another victim blaming. Based on multiple factors, confusion. No conclusion can be drawn. You see, so it's worked in the negative as opposed to the positive. And as people should know, is that we're not scientifically proving our cases. We're doing on the balance of probabilities, not 97%, but 51%. And so they reverse that no conclusion can be drawn. They're talking about no certainty. But they use that language, as they did often the language with when OxyContin and Purdue used the language, where they use language to defeat the case. And there, the language, and I'm not going to get much into that particular case, but which we did that case, was they talked about abuse. We talked about addiction. You see, the language means a lot. And so, abuse is victim blaming, addiction is product blaming. So that's the kind of thing that they will use. These are quotes actually from submissions made by in the right pro femur case, and this is all public record. But the study in the petroleum industry too do the same thing. They call on the playbook from tobacco. Purdue did it in OxyContin, and it continues, and it works to the public, because the public is innocent to the burden of proof that we have in these cases.
Yeah. I once built a team for a U.S. law firm, needed a defense firm against class action, transvaginal mesh, and we built a team of nurses to kind of analyze the medical records. And of course, the defense was very vigorous, and they sent us medical records from birth until the 3 to 5 years after the mesh had been implanted. And our job was to look for absolutely positively anything that could be contributory to the injury outside of the transvaginal mesh or anything to do with it. And it was really an eye-opener for me, because the stuff that they ask us to identify was, you could see that somehow in a big, long stretch of imagination, you could connect the dots between those two things. But, as a nurse, you understood you really can't. But anyway, that was an eye-opener for me. But let's move on, because I feel like I could talk about this with you for days. But I'm interested. You brought up a class action case that you're working on now that you'd like to discuss. And why don't you share those details with us now, and then we'll talk a bit more.
Yeah, so this is one of the metal-on-metal implants that became very popular in the early 2000s. And there's a number, the one we worked on, we actually worked on a number of them, but the primary one that we did, I should say one thing about class actions too. Sometimes you work by yourself. Sometimes you work with small groups. Sometimes you work with large groups. And dealing with personalities of strong personalities with a number of people is very difficult. This was a particular case that we had done on our own. And it was the hip pro-femur Z. And we had, this started back in 2000. The class was certified in 2014. We had 43 clients in that particular case. And it was basically it comes with, so you have the ball and it comes down the stem, and the stem fits in within the socket, and it has this particular tape that stops it from moving around. It's a mechanism that's basically pounded into it. Excuse me. The problem is this is titanium, metal on metal, and eventually with usage, it would kind of chip a bit and then develop cracks, and then eventually catastrophic fracture for those people that had the particular implant.
And just to be clear, is a catastrophic fracture of the femur or the...
It's the stem. It's just above the stem. There was a particular point at which most of these fractures took place. Now you start seeing what makes it common is that the fracture site is generally in the same area within an inch or 2 inches of the interface.
And how do you define a catastrophic fracture? Like, what happens?
That's medical description of it. If you have a complete failure of a medical device like a hip, if it fractures, that is a catastrophic fracture of that device. It doesn't relate to the impact that it has because there's variable impacts that it can have on a particular patient. Revision is going to be universal. But some develop infection, and of course the implant doesn't last as the 20 years that it's supposed to last. You got a second one, scarring. There's a whole host of things that can happen as a result of that, including additional lost labor time, the cost of care. You need somebody to care for you, and of course the risks of a second operation is greater than just having one. So this case went on, and it was certified in 2014, appealed to the Court of Appeal, the Nova Scotia Court of Appeal, and eventually we won there, and eventually the Supreme Court of Canada, and they refused to hear them on that. And so when we look at a class action, you got to define your class. And the class here is all, so we define them, and it has to be objective, so anybody knows whether they're in or out. And so the class here was anybody in Canada who suffered a fracture of the right pro-femur Z implant between the age of the February 2001, when it came here, to the time that we get the final order of the court, because people may have fractures afterwards. And we can't settle their case because you can't have a personal injury case unless there's harm, and there's no harm, so you can't settle those future cases. So you create a class period, a very defined, that's your class, and anybody, regardless of whether they call us or not, if the case resolved successfully, which it did, and we eventually mediated it, we didn't get to the common issues trial. That is the kind of course that it takes. You say about it, it's back to the point at which if somebody in Kamloops, BC, had a fracture, and I'm filing this case in Nova Scotia for certify a national class, which we did. It's a national class. So we represented all Canadians who fit within that class definition. And they don't have to contact us until such time as we're in the settlement process. And the settlement process generally takes 9 to 18 months. And you can submit a claim regardless of whether you contacted or did anything before then. And so we went from... Right. So when somebody says, "Oh, I missed out on the class action, I didn't sign up," the key information is, has it gone through a claims period yet? And if it hasn't, your rights are still all preserved. And you can call up and contact the claims administrator and advance the case. We calculated a settlement that at the event eventually, you often what you get is cap settlement. So one of the big difficulty and big problems is to try to find out, trying to calculate how many people across Canada actually had this failure of this particular device, and you don't know for sure. So what we did is you send out notices to all orthopedic clinics so they can post it up their boards so the physicians know about it. And you also try to hint to them that we're not trying to sue you for it's really, this is a product case, not a medical malpractice case. So you advise your clients and send them to us, and we did it in doctors' offices, orthopedic surgeons, and hospitals.
And how does that go, Ray? Are physicians generally receptive to pass that information on to their clients or their patients?
Well, I think a lot of the physicians are very concerned about any involvement in the legal process.
That's the understatement of the day.
And a lot of people just want to practice medicine. They don't want anything to do with litigation. They don't want to give you a report, and they don't want to comment on anybody's care, regardless if it's 10 provinces away. It doesn't matter. So, that's a difficulty in medical malpractice generally, of which you know. And so we did all this work, and then we had 43. At the end of the day, I think we had number, I have it here somewhere, 62 cases. We provided the compensation up to 65 patients, and so you get a cap fund. And so you got to be, if you got 160 cases, then everybody's proportion is going to go down significantly. So it's a critical part of class proceedings is to try to get a sense of the magnitude of your class and how many patients you're ultimately going to get. Some of the stuff that we've done, we've been really good at, and this is one case where we were really good at it. But I think it's a lot of luck.
So tell me, does everybody have to wait before they get their money until everybody signs up or signs in or makes their claim? Or do you get your money? Like, did you come up with an average amount? And I don't know if you can share that amount with us, but if you can, did you come up with an average amount per patient, or is it dependent on the type of injury they had? And do people have to wait until the end of all the submissions that come in before they get their money?
So what happens is, well, you go to court after you have a court approval process, because the court has to prove that it's fair and reasonable for the class. Because lawyers could, conspire with and collaborate with the defendant just to settle the case for fees, right? That be suspicion, and there are very, very few doctors that are uncaring. There are very, very few lawyers that would pursue that line of action. There are always a few. There's every bunch, every class, every group. There's always some that cause harm to the rest of the good serving people in that group. So you go to court, you get it approved, and then the approval goes through, and then there's a notice program that's established and approved by the court. And it tells you how to distribute notice so that we can have maximum uptake. Sometimes if we have the names of the individuals, they get direct notice of when they submit the claim, and then when the claim period is over. And that's usually, I mentioned earlier, 9 to 18 months. So it can be a shorter period. If you have a really discrete class and you know that you have everybody, you can do it in 30 or 60 days. But if you're trying to reach out to people that haven't come forward yet, it's a longer period. And if you don't come forward in that period and you had a fracture, and after the claims period ends, you have no claim. You can't start an individual claim. You're done. Unless, of course, you're outside the definition of the class, which is the date that the court certified or approved the settlement, which would be the date. If any fractures after that, you're not in the class anyways. And you can pursue your own action.
Yeah, what a challenge though for you, to to reach everybody who's been involved. What let's take us down the road a little bit. What happened with that hip implant? Were there changes, alterations? Was it taken off the market? What's happened with that particular implant?
Well, they were sold. It was Wright sold it to another company, Port something. I forget. I don't have it right here in front of me. Sold it to another company. As far as I understand, that the device is not being used now. That was a problem with the titanium implants, the so-called metal on metal implants. There was Zimmer, Biomet, Dupuis, or they were all are subject to class actions, and we had filed actions on all of those. But other firms were doing them, and I prefer to. I like to do our own stuff. I don't like to. Not that I'm not collaborative, and I will collaborate with people, but I find it slows things down, and it's complicated, and it's like ruling. I think any physician or any nurse out there would know that when you have to go to committees and things got to be decided by committees, how slow it goes.
Exactly, exactly. That's probably why you are, the owner of your own firm. One reason what makes life easy.
I'm not a good collaborator, I think. Maybe.
Oh, well, thanks for sharing those details. And has that period to claim closed, or is it still open?
It's closed. But if somebody had a fracture after that period, time, which I think was approval was in, yeah, I think it was around 2020, January 6th, 2020. But they had they really had no physician that I was aware of was implanting those after the multiple fractures. Some of the physicians were commenting, people that were doing revisions, that they're commenting to the general medical community. So I think it really kind of stopped that whole business of metal.
That just got to be a sick feeling all the way around from the physician, and it erodes the trust in the equipment and the manufacturers and the companies, and the reps who show up at the hospital selling the equipment, all that stuff. I have another question for you, then I'm going to ask you just a couple more. But I sort of opened this podcast up talking about what's reasonable for us as healthcare consumers to expect when we enter a hospital of equipment and the users and the upkeep and the information obtained from it. Do you have thoughts, or can you share with us, like, what's the court's view, like when a case like this where there's obvious malfunction of equipment, or we're not talking operator error here, we're talking equipment error, whether it's manufacturing or distribution or whatever, the wear and tear that happens. What's the court's view? Like, how do they come out against this and say, you know, you guys, like, come on, what's the legal view of the responsibility of the manufacturers and distributors of medical equipment?
There's a lot of problems that arise in that, and it's profit versus safety, and that's the tension. And some manufacturers, knowing, and in this particular case, knew that they were having fractures at a rate, that wasn't extreme, but it was double, triple what the expected rate. There would be fractures every now and then for whatever reason. It's not perfect. So so when the courts look at that, if you have the evidence, you're going to win your case. Now the thing is to get critical evidence, but to get critical evidence, you have to get all the documentation. And what often happens with the manufacturers is that they'll start. You want documentation? Yeah, we'll give you documentation. So we'll give you a batch of 10,000 documents now, and then you have to go and say, well, that doesn't include the critical stuff we're looking for. What are you looking for? Well, we're looking for your testing. Oh, okay, testing. Yeah, we'll give you those, and we'll dump a bunch of that on you. And so that may be another 10,000 documents, and then you go through all the testing. It says, well, it didn't include anything on marketing. Uh, oh, yeah, well, you want marketing too. Okay, we'll give you marketing, so that's another 10,000. And if you don't give it to us by a certain day, we're going to have to go to court. You have to threaten, and you do all those things. And sometimes you do have to go to court to get orders. But it's the constant obstruction that unfortunately is weighing down the judicial system in a big way. Because because delay, delay, delay. And I've seen way too many delays. And the big thing that I speak about, and every time I got an ear, is that there's way too many procedures in a piece of litigation. We should start it and finish it in a very discrete, short period of time. And it may be rough. And some winners are going to lose, and some losers are going to win. But let's get it out of everybody's life. And I think the patient that has, that's suffering with no compensation, having to deal with, if they're a paraplegia, quadriplegia, or whatever kind of care, and they're just dealing with the bottom level care that they can get. But I also think of the nurse and the physician who are sitting around with this thing hanging over their head. And if I did something wrong, let's just deal with it, and I can deal with it and move on with my life, as opposed to constantly wearing me down, whether I, question whether I should continue in doing what I'm doing. And so I feel it on both sides, and I think it is a real problem. And I constantly speak about it at every time that I get an opportunity. But thanks for giving me that, even though you didn't.
Yeah, no, that's really good. And you're so right. I think I'm just about to record a podcast in the next few weeks on trauma-informed lawyering, and really hitting what is that. Well, first of all, to inform lawyers and what they're dealing with on an emotional level, even though I'm sure many of you experienced ones know that already, but because you just, verbalize that very well. But the experience of the patient living and reliving and living and reliving the event that's happened to them that's, considerably altered their life.
Yeah, we're a big fan of trauma-informed lawyering, and we do it, and everybody in our office has gone through sessions on it. One of the big things we do, and especially in the class-wide situation, is restorative justice. We don't go into a class action. Now, sometimes in products defects, but we're dealing with other cases where you're dealing with, even in product defects, but in other cases, more emotional ones that are driven by emotion, is that we don't go in and try to be bombastic and try to bring some pedophile to justice. It's not what we're doing. So we're trying to take that group of people that has been harmed so much, and to be able to bring them through a process that we're not going to re-victimize them, and we're not going to leave them behind, and hopefully they can grow better from the whole process. So this is that's a reflection on restorative justice, and I think in the medical field, there should be a lot more. There should be a lot of these cases should be resolved in a restorative fashion, so it doesn't have to become public. It doesn't, people, and it's reputational with doctors and nurses, especially doctors who would like them to be mobile. These are big issues, and they get in the way of resolving these cases because they're career impacting issues. And so there has to be a better way, a better process that if the parties choose it. Now, if they don't choose, they want to litigate, then that's fine. But if they choose it, let's go through almost an arbitration, and I akin it to arbitration. Let's just say, okay, the defendant with a notice, do you wish to go to arbitration on this fact pattern? And they respond, yes, we would like to do that. Well, you can deliver that outcome in a very short period of time if both parties agree. So I would do that tomorrow on a case if I could get one of the defendants to agree to that process, as opposed to, because what's going on now, and I feel sorry for the nurses and doctors that are caught up in the system, because right now it's warfare. It's warfare, and you have to go. And we got a case coming up in September that we're investing about $400,000 by the time we're finished with it. That's our own money and stuff like that. Very few people can do it. And, maybe that's a deterrent to medical malpractice. But there's a better way to do this that you can be very efficient and can be fair to both sides of the piece of litigation. Take it out of the courts. Give it to arbitration. Yeah, the clearest of cases should be done that way. Because despite, and again, I don't mean to pick on the CMPA, but I will for this moment, despite saying they'll resolve the clearest of cases, of all the cases we haven't seen a clear one in the mind of the CMPA. And I think there has to be a shake up there, and I think it's something that I think would benefit everybody. But again, I'm on a soapbox now about this as well. You hit a nerve with me. I really do think it'd be better for everybody, and certainly on an emotional level, better for everybody.
Well, I appreciate that. Like, as a healthcare provider, I mean, your understanding of how hard it is for doctors and nurses is absolutely true. It's devastating, and it takes a lot of people out of healthcare. Just the threat of a lawsuit, just the statement of claim or notice will take bright, shiny nurses and doctors out of healthcare forever. So, thank you for that. And I mean, I'm sure there's a lot of people that agree with every single word you just said. And I understand that you might be stepping out of your active pursuit of your legal practice before so long. So there's your plan B right there. There's, Ray for president. Let's go. Well, let's wrap this one up. We're going to do a second podcast with Ray where we're going to talk a little bit more personally about him. But we've covered a lot of big information here. And thank you so much, Ray, for both your compassionate view of all sides and your knowledge, your sharing of your knowledge. But I'm going to ask you a big question that I ask at the end of every podcast. And because listeners include lawyers, doctors, and nurses, and the general public, I'd like for you to answer for each audience, what is the most important thing that you would like them to know about equipment errors? So let's start with doctors and nurses. What is the biggest thing that you'd like doctors and nurses to know about equipment error litigation and or class action?
Yeah, I think, there are two different things. Of course, class action, that this is happening repetitively. And, it's a call to action, and it should be reported and to Health Canada. But Health Canada is understaffed enough, and you can't get very far with them anyways for a number of reasons. But I think, what's key to me is I would say for nurses and doctors is to be honest and forthright about it in the documentation that you file with respect to the event that is there, and to provide the detail. It's not welcoming litigation. It's just saying, look, if somebody's been harmed and a product did that, then we need, the patient needs to know, or somebody is consulting. And I think being honest with the patient as well. One of the things I've been saying a long time is that the people that come to our office are the people that have had something happen to them and they don't know anything about it. They just know that something bad happened. Now, out of 100 cases, 4 of them had it because of medical error. The rest just happened to have a bad experience, and that's just bad outcome. But they contact us because they don't know. They don't have any information. And, we have apology acts now where people can apologize, and that's fine. It doesn't mean that you caused the harm anyways if you apologize for the outcome. And so I think in a large element of compassion and information and being fair and honest, clients often say, I would never have done this had I been informed properly what had happened, and I got an apology, and they come together and say that this is life experiences, and it comes to a different place than this adversarial stuff. It's more like coming together. And so I say, be honest and forthright. And even if you're a part of that error, I would also say that, you operated improperly, didn't have proper training or whatever, which I think is actually more a hospital issue than it is an individual issue, because you're often thrown in those circumstances that you got to do something. Is to be honest and forthright, and cut down the amount of litigation that we do. It would, and certainly for sure, the amount of phone calls that we get.
Good, great advice there. Great advice. What about for the general public? What would you like to say to them? The most important thing they should know about equipment errors.
The most important thing, and I'm sure people have heard it before, is that ask questions, get information. If you're not able to ask questions, get somebody on your side, a family member, friend. You can even do a patient advocate, but I prefer to go outside that. I mean, many of them are very good, but they're in a difficult situation too. So I would have to ask questions, be informed, and just don't take, this is what we should do. Why are we doing this way? And it's really informed consent, and it's a part of the law of Canada that you have to be informed. But I think you really do have to take care of your own health care. Partly, large part because of the fractured system that I spoke of before, when you're transitioning from one specialty to another in a complex situation, trying to find a proper diagnosis and going through different differentials. You just get information because it can help you. And, the nurse or the doctor has gone home for the evening. They're not back till tomorrow. If you know what's going on and you're imparted with this information that can take care of your own health care, then you're wise to ask those questions and to keep informed. And don't take, this is the way we do it. Why is this the way to do it? Is there alternatives? What are the risks? And get into that information. I know it takes up time for healthcare providers, but it's critically important for patients.
That is another solid piece of advice, Ray. Thank you for that. For patients, that's great advice. So what about other lawyers who, I don't know if you want to talk to them about if they have equipment error cases or what they're looking for, how to litigate them. What general advice would you have to lawyers about equipment error?
Yeah, lawyers, we can practice in any field. And if you're an experienced lawyer in it, I don't have to tell you anything. You know what to do. But in the involvement of equipment, I would say generally, again, you ask questions, you have to probe on those because you don't want to be caught blindsided with, at the end of the day, that say, well, the equipment malfunctioned on this day because the plug was chafed a bit or something like that. And that's what caused an electrical malfunction in the equipment or something like that. You got to know that information. It doesn't mean you have to go back to the manufacturer and say whether they properly manufactured cords or anything like that. But the other thing I would say too for lawyers is that there's a lot of lawyers out there. I'm surprised. I get very few calls from people when they have a medical malpractice. I know how difficult the area is. And I know that if you're doing your first cases, which I did and I started doing med mals back in '94 on a serious basis. So I've been doing it a long time. Is that you don't have to give the case away. You don't have to refer it. Just to have a buddy that you can throw some quick questions at, who has practiced in that particular area. And I'm just surprised, frankly, and I've offered mentoring and stuff like that. So I mentor in the office here all the time. And we do it, and we're a collaborative office. I always say we're more socialist than we are capitalist. So we kind of work together for the common good of each other as opposed to the individual good of one. And so I think that's very important. Don't be scared to pick up the phone because most of the senior practitioners love to share their knowledge. It makes them feel needed. And so I would say do that.
That's really good. And I just want to say you're not the only senior lawyer in the country who said that, how much they enjoy collaborating or consulting on cases and really do appreciate being able to share their knowledge in this very highly specialized area of the law. So, good one. All right. Well, I think with that, we've been talking a nice long time. I just want to say thank you so much, Ray, for your compassion, for your sharing of information, for your knowledge, and for your openness. It's been a pleasure. And I just want to say, I mean, I don't know Ray really well, but we've certainly spent some time together. And this is him all the time. This is him at dinner. This is him in the courtroom. This is him having a podcast. He's just this guy. And it's so comfortable and easy talking to you. And I really have appreciated this time. So thank you so much.
Well, thank you very much, Chris. It was a pleasure.
I also want to say a very special thanks to all of you who are listening in. If you enjoyed this podcast, please like and subscribe and leave us a review. And don't forget that in many jurisdictions in both Canada and the US, doctors, nurses, and lawyers can claim continuing education for listening in. The podcast is available on all the usual platforms. And for nurses in the United States, you can listen and receive credit on CE Broker. We've also just announced a live 4-day conference, our first since 2018, thanks to COVID and 1,000 other things that were going on. And it's titled the Essential Legal Nurse Consulting Conference that will be held in Calgary in October of this year. If you're interested in the fascinating role of legal nurse consulting, which is what I've been doing for 20 plus years, please check out our website, www.connectmlx.com, and click on education. And be sure to tune into the podcast over the coming months as we further break down the issue of communication issues in healthcare, that we're going to take a look at the very messy business of infection control in healthcare. And we're also going to talk about, as I mentioned earlier, trauma-informed lawyering, and hear from a patient, her perspective of what it was like to live and relive the outcome and the events that happened in her malpractice case. So thank you, goodbye, and take good care.